this project is about looking at people who we're seeing at Peter Mac who finished their treatment many years earlier. They're still having follow-up, and we're really questioning whether or not we should be continuing to see people regularly and whether the follow-up represents pretty low-value care. So there may be circumstances where people are being seen and there's no clear indication for why they're having regular follow-up. And this, of course, compromises the ability to see people, new patients promptly, because if all of our outpatient clinics are filled with review appointments, we can't get in the new patients. So what we're hoping to do in this project is to be able to discharge up to 50 people who are in long-term follow-up. And we've focused particularly on follow-up where people are being seen by either radiation or medical oncology. And through this project, we also wanted to develop discharge protocols. So defining who we should be seeing, who should be seeing them, and what are the criteria for discharge. So our aim is to reduce low-value follow-up where it doesn't really accord with evidence-based follow-up guidelines. Sorry, trying to look everywhere. And where these review appointments may represent low-value care. And by reducing the low-value care, we can release capacity in outpatient clinics, support more timely reviews, and also reduce unfunded activity, because a lot of hospitals are doing more activity than what they're funded for. And as I mentioned, the target is 50 patients. So to date, we've been working with our analytics department. So here it's called Business Intelligence and Analytics. And we've developed a surrogate definition of who are long-term survivors. And this is something I'm really keen to discuss with everybody about how we define the survivor cohort. But we've defined it as people who had treatment at Peter Mac, not currently having treatment, and that treatment completed for the sake of this exercise more than 5 years prior. They're not having continuing follow-up, but they're not having continuing treatment, but they are booked for regular follow-up appointments. They don't appear to have advanced disease, and they're not seeing palliative care. And we've done quite a lot of work trying to audit this population. And what we've actually found is that this definition does not really define the cohort in the way that we thought it would. And only about 15% of the patients we've audited actually represent long-term disease-free survivors. And the reasons why are that many people actually, we're capturing people who still have advanced or recurrent disease. We thought that a large proportion of, so there were several hundred people being seen by radiation oncology in the urology service, and many of these people actually have evidence of biochemical recurrence. So people with a PSA that's rising that we thought were disease-free, but they're not. Another proportion of people have actually already been discharged. We're also capturing people who are requiring long-term follow-up on clinical trials. So our next steps really are to continue to work with business intelligence, because we need this data to be better so we can then share it with clinical services. We're working very closely, particularly with radiation oncology and medical oncology, on trying to work out how do we define appropriate follow-up? So that's the bottom point about who should be seeing people, how often, how frequently. And this is part of a process of moving away from medically led follow-up to other models like nurse-led follow-up, shared care, and GP-led care. And we're also looking at other cohorts. So we started with Peter Mac at Parkville, but there's a lot of follow-up at Peter Mac and Moorabbin and other sites. So we're moving to other sites. And also inevitably we'll extend from just looking at radiation oncology and medical oncology to surgical review and hematology-led review. So I'll leave it there.